Assalamualaikum and good day to you. So I'm going to talk about patient selection for daycare anesthesia. So this is part of the anesthesia scientific meeting of Malaysian Society of Anaesthesiology (MSA) 2023. Okay, so I'm recording this talk so I can talk and explain slowly to you rather than having to explain very fast in the event during the conference. So I'm from University of Malaysia Sabah. So I'm an anesthesiology and critical care specialist. So this is our future upcoming hospital, HUMS. So it is the first teaching university hospital in Borneo, and it will be officially open in 2025. So the work is being very good, excellent progress, and it's a 400 bed plus bedded smart hospital. So it's expandable to 800 bedded. So we have 25 operating theaters, 24 ICU beds, and we have 5 out of 25 OTs will be daycare OT. So it's up to 20%. So we know that daycare surgery, ambulatory surgery is the way to go towards the future because patient can recover faster, patient can recover at home. Of course, when we are a patient, we would like to go back home as soon as possible. We don't want to be in the hospital. Okay, it's depressing to see sick patient. Okay, it's mentally better for the patient and also it's what the patient prefer. So if possible, all the patients will want to do surgery in daycare. Come in the morning and go back in the afternoon. Okay, in the evening. So, but unfortunately, not everyone can do daycare surgery, and also it's also very important to understand what are the important factors that involved in choosing the right patient. Okay, and we know going forward, ambulatory surgery will be the way of the future for elective surgery. So, having said that, showing you my hospital, so the vacancy for my faculty is open all year long. Okay, so you can apply. All right. So, my talk will be based on this uh, review article as well as from the Society of for Ambulatory Anesthesia. And then I will be focusing on a matter of time and clock. Okay, so I'll be focusing on the type of when we want to select patient for daycare anesthesia, we want to focus on the type of facility, patient comorbidity, surgical procedure itself, social factors, and what usually we talk when we think about choosing patient selection in daycare anesthesia, and when we talk about daycare surgery in general, we will think about speed and time taken and safety of the patient as well as the efficiency of the daycare surgery itself. All right. So we talk about the type of facility and social factor first. So type of facility of ambulatory surgery or daycare surgery center can be within a physical hospital environment, or can be an independent daycare not connected to any hospital. So they are the two main type of ambulatory surgery. All right. So when we talk about type of facility, we are talking about the risk tolerance towards safety of the patient. Uh, in choosing the right patient to be done in the facility. So not, for example, for daycare surgery center within a hospital environment, you can do more complex surgery because you have more backups and you have more consultants and so on. While independent daycare not connected to any hospital, you can only do low risk procedure. And of course, when you have daycare surgery center in a physical hospital environment, not only you can do more complex surgery, you can also qualify higher risk patients, while in the independent daycare, not connected to any hospital, you can only do lower risk patients. Okay, so the advantage of having daycare surgery center within the physical hospital environment is that you have services of blood bank, other specialties consult, diagnostic laboratory, and you have unexpected admission post surgery. You can just admit to the hospital without no issues. And then we also think about the operation hours because daycare surgery center can operate for longer hours from the 7 a.m. until 6 p.m. But independent daycare, you may not be able to open that long. Okay. So when operation hours is being discussed, is also involved the what type of surgery and the length of surgery that can be performed in the facility. So this also will impact the type of patient that you want to select for the when you are doing the daycare anesthesia in ambulatory surgery. So it's very important to note that social factors is one of the main factor very to be able for the patient to be selected to go to daycare surgery. So you need to have the patient need to have availability of responsible individual, and from research we know that health literacy of the designated individuals is very important. Those who accompany the patient to do the daycare surgery, and then what matters also is the location of patient's home and also the living condition suitability for post-surgery care. All of these four factors will influence the complexity of surgery and will also affect the complexity of post-op order, which in turn will affect the what type of surgery that can be performed and what type of patient can be selected for the daycare surgery, for daycare anesthesia. And also, when you talk about time, it's also you need to think about accessibility to the patient, of the patient to the daycare surgery. Okay, and then you need to also think about about speed, how fast the patient can come back to the hospital if any problem occurs. Okay, so next we talk about patient comorbidity and surgical procedure. Okay, so we talk about surgical procedure first. It's the surgery itself and also the surgeon. Okay, so the surgeon, of course, we all know, but many of the other our counterpart may not admit. But the skill of the surgeon is very important because the faster you do the surgery, the lesser the risk for the patient, the more cases you can do, and the more complex type of patient you can take. Okay, so the surgery itself, when we talk about surgery in choosing the patient, what type of patient that we can choose is also depending on what type of surgery that usually can be done in a daycare surgery center or ambulatory surgery center, because it also affect the likelihood need admission of post-op into the ward. Okay, so like invasiveness of surgical procedure. So we want to do minimally invasive procedure uh, to be done in daycare surgery. Okay, you need to be able to control post-op pain. You don't want to do operation or surgery which involve a lot of post-op pain and uncontrollable post-op pain. So this type of patient you need to admit to the ward. Okay, and then you need to do surgery which does not have the need for special post-op parenteral therapy. Like when you do gastrectomy, you need to put a IV central line to give parenteral, TPN, and so on. So if the patient will likely to have this TPN, so they may not be suitable for daycare surgery. And also the surgery must not be having any potential significant blood loss. Of course, sometimes we can't predict it, but we know certain cases that are already implicated with a significant blood loss. So these are the type of surgery and patient that we may not do in daycare surgery because they may have higher likelihood to be admitted post-op. And also the expected length of surgery. So surgery that can go on and on and on, they can't be finished in time. So we can't do it in the daycare surgery. So you need to be honest with the capability of the surgeon and also the anesthesiologist. Okay, so the surgeon itself, not only the skill of the surgeon is important, the skill of the surgeon not only is important for the duration, it's also important for the potential significant blood loss and also the expected length of the surgery. So this may affect what type of surgery that can be done by the surgeon, by the skillful surgeon. Also, what type of the patient that can be selected for the care surgery because of the surgeon doing it. Okay. So the speed of the surgeon and the speed of the surgery determine the suitability of the surgery does the patient. Okay. So you need for this to be done properly, you need to have an efficient perioperative work process to ensure better outcome. And then we talk about patient comorbidity. So this is the main chunk of the patient. How do we select patient for the care surgery? So we divide into age and ASA physical status and malignant hyperthermia and also chronic pain opioid disorders. So for malignant hyperthermia, Society for Ambulatory Anesthesia said patient which having a history of malignant hyperthermia, you can do in daycare surgery, but you need to be careful and use non-triggering anesthetic. So the availability of the antroline and the training, the drill to manage malarial hyperthermia, if of course will already be there, regardless you do the patient in the care surgery or elective surgery in the major OT. So this is cannot be compromised. But what is being highlighted and emphasized is that you need to use non-triggering anesthetic like propofol. Okay, so for chronic pain or opioid use disorders, patient with chronic pain or having use of opioid use, so you need to involve input from the pain specialist. You may involve them in daycare surgery, but they are somewhat a complex patient. Okay, I mean in general, you can continue baseline opioid equivalent plus local origin anesthesia, then usual precaution if patient is on methadone. Okay, so let's go into the age. So usually the age limits patient older than 75 years. Okay. So in the old MOH protocol in 2012, so they say patient older than 75 years old and less than 6 months old should not be selected for daycare surgery. And then they updated in 2017, where the age for selection for daycare surgery is 6 months to 75 years old. So patient more than 75 years and children less than 6 months may be considered on a case-to-case basis. Okay. So it's also important to note that the type of facility that you have and the social factors may play a role in selecting the patient. Okay, so the type of facility, whether you can handle a baby, whether you have pediatric anesthetist, whether you have a geriatrician or anesthesiologists who are very well adapted to deal with geriatric population. So this uh, also, whether the patient have appropriate caregiver to handle either younger than 6 months old or more than 75 years old. But it really depends on the local facility and local policy. So if you cannot handle 6 months to 2 years, you may not do this type of patient in your daycare surgery. So it really depends on the type of facility and how good your personnel can handle it. Okay, so you need to keep in mind that post-op complication when elderly patient doing ambulatory surgery can increase when they are very old, more than 80 years old. Otherwise, age number should not be the only consideration. Improvement in selection optimization will improve outcome in patient going for ambulatory surgery for elderly patient. And what is more important is to assess for frailty and functional capacity. You need to either use clinical frailty scale or Edmonton frailty scale. And you need to do comprehensive geriatric assessment needed if elderly frail. And you can find my YouTube recording also for this specific anesthesia for elderly approach. So these are the approach that I already summarized. Okay. So next we talk about the ASA physical status. So in the AAGBI guidelines for daycare for surgery in 2019. So they say is the determination of selection of patient should not be by ASA physical status, but is it? Okay, so in the recent guideline, in the recent publication in 2021, where the ASA being studied, ASA physical being studied in 2 million cases from the America, so they found that in laparoscopic cholecystectomy, lap appendicectomy, and inguinal hernia, so the regional anesthesia is is safer than MAC or sedation and is more safer than general anesthesia with a mortality as odds ratio of 1.67, 1.68, and 1.91. So as you can see here from the graph here, the higher your ASA physical status, the higher is the medical complication, mortality, and readmission. So when we talk about the type of anesthesia, the regional anesthesia is actually seem to be the safer in terms of the higher ASA status. So when you have a higher patient at ASA 3, this is at ASA 3. So at ASA 3, regional anesthesia is found to be associated with lower mortality compared to MAC sedation, and also is better than general anesthesia. So this is the finding from the retrospective study. And then if you see the protocol 2017 MOH protocol for daycare anesthesia, patient classified in category ASA 1 and 2 is suitable for surgical daycare surgery, and patient in category ASA 3 can be selected after consultation with an team provided comorbidities are optimized. So you need to optimize the comorbidities. So International Anesthesia Research Society suggests that ASA 1 and 2 you can do. ASA 3 you need to optimize the comorbidities, and ASA 4 only simple LA based procedures or in cataract surgery you can do, because ASA 4 is already very high, associated with very high risk and poor outcome. So you need to do it in the elective surgery. Okay. So one of the commonly cited study is this study by Ansel, outcome of ASA 3 patient undergoing daycare surgery, where he did a retrospective observational study in 896 patients. So they showed that no difference between ASA 1 and 2 when ASA 1 2 versus ASA 3 in terms of admission of post daycare surgery, which is admission will be is low, about 1.9 to 2.6%, and the drowsiness, nausea, bleeding, and pain is all almost the same between ASA 3 and less than ASA 3. Okay. So next we talk about obesity. Obesity is involved with obesity-specific anesthesia risk, where they have difficult mask ventilation and intubation, difficult insertion, shorter safe apnea time, pulmonary occlusion risk, challenging resuscitation intraoperatively, and post-op pulmonary complication. And there are also obesity-related comorbidities where this type of patient is highly contraindicated to go for daycare surgery, like obesity, hyperventilation syndrome, severe pulmonary hypertension, severe coronary disease, and heart failure. Okay, so you can read anesthesia for this obese patient in this QR code that I've given now. Okay, so any BMI cutoff. The old 2012 MOH daycare protocol mentioned BMI less than 35, but dropped out of the 2017 protocol. However, evidences available are not enough. So BMI cutoff more than 40, which is equivalent in the ASA 3, is usually previously being said as the cutoff, but the new evidence say the systematic reviews of evidences in 2012 and 2016 by the Joshi group. Joshi et al. Is the group that always do studies in ambulatory surgery, concluded that supermorbid obese BMI more than 50 have increased postoperative morbidity and mortality. Okay, so in this research by Haj Mohammed, so where he did a case control study, compare between 7,160 patients between under 7,160 case control propensity match study. So you can see there is a similar outcome between BMI 40 to 50 or BMI more than 50. So actually, what really matters is that it's not the obesity per se, it's the what comes with the obesity. You need to manage the comorbidity appropriately. Okay, so means to say that you can do higher and higher BMI, but it also depends on how good you can handle it. And then the patient comorbidity, hypertension, AAGBI say BP less than 180 over 110 is a reasonable target. Uh, if DVP more than 110, cancel or delay if symptomatic or acute and organ damage. Coronary artery disease, low risk surgery, MACE less than 1% plus METs more than 4. No further testing needed. Delay surgery at least 30 days after ACS. For heart failure, LVEF less than 35% has a greater risk for all cause and cardiac mortality, and you need to optimize the heart failure and LVEF. You need to do in daycare in tertiary center only. For valvular heart disease, you need to be cautious in severe stenotic lesion and only allow low risk surgery and only in tertiary centers. For atrial fibrillation, new onset and asymptomatic AF contraindicated for day surgery. Chronic and optimized AF you can allow, and bridging anticoagulation case to case basis. For coronary artery stent, you need to balance the risk of bleeding versus risk of stent thrombosis when you want to think about stopping the antiplatelet. For patient with cardiac implantable device, you need to ensure the comorbid optimized and perioperative CIEDs management as usual. And then for OSA is is an underdiagnosed condition, and stop bank is the most validated and used tool to predict having OSA. So you need to avoid day surgery in optimized comorbidities, surgery near or involving airways and obesity hyperventilation syndrome. and you need to use opioid-free or sparing approach as OSA patient has increased sensitivity to opioid. So as you can see here, the main important aspect is that you want to be able to manage them with non-opioid analgesic technique. So for COPD and end-stage renal failure, COPD independent risk factor for adverse outcome in day surgery related to increased severity of frailty, functional capacity restriction, severity of symptom and compliance of therapy, severe disease patient, you need to do lung function test, and FEV1 less than 0.75 not suitable for daycare surgery. Instead, renal failure patients are safe to undergo daycare surgery. You need to optimize the comorbidity, you need to accept the chronic anemia and cardiac ischemia, asymptomatic mild hyperkalemia, anticipation of difficult IV access. In a safety study by Rao et al. 2014, shown post-op complications were related to presence of heart failure and prior cardiac surgery. AVF creation was proven safer and lower complication when done using LA or regional anesthesia. Margulis et al. Show there is 3 times lower admission in daycare surgery patient compared to inpatient surgeries. So for TIA and stroke, in this study in the Danish cohort, a subgroup of patients with among higher risk for post-op complication, where odds ratio is highest in the first 3 months after TIA or stroke, and then it becomes lower and lower, but it still remain elevated even after 1 year. So, but after 9 months, the risk is already stabilized, but still remain elevated 2 times elevated than the normal population. So for antiplatelet therapy, most of them will have this, and the comprehensive individual risk benefit assessment need to be done. So take home message, when you want to choose select patient for the daycare anesthesia, you need to balance between risk and benefit. You need to remember the 4 quadrant factors to choose, where social factors is important for patient to have uh, accompanying person for immediate and early post-op care management. You need to be able to manage time properly, because rapidity of onset of anesthesia technique is very important, and offset of anesthesia and complication to anesthesia you need to take into account. You can use regional anesthesia technique advancement, can help you to save time and for the recovery of the patient. You need to think of the type of the facility involved and patient comorbidity. This affect the complexity of patient with their innate risk, and you need to think about the surgical procedure. Complexity of surgery means how complex the surgery will be able to perform in the ambulatory center. So speed and efficiency in daycare surgery will lead to patient and surgeon satisfaction, but uh, when you uh, when you're able to ensure patient underwent a safe surgery and safe anesthesia, this is the pinnacle of anesthesiology satisfaction. With that, thank you.